Today we will be performing a physical respiratory assessment. Perform hand hygiene before entering the patient's room. Introduce yourself and ask for your patient's full name and date of birth. If in a hospital setting, verify the accuracy of this information with the patient's ID bracelet. If in a clinic setting where no bracelet is present, make sure the information the patient gives you matches previous documentation. Explain to the patient what you will be doing. In this case, I will explain to my patient that I'm here to perform a full respiratory assessment. I will tell them that I will be touching them around the chest area and using my stethoscope to listen to their lungs. Always ask for consent and let your patient know they have the right to refuse at any point. Make sure you have gathered all the relevant information needed before starting any physical assessment. In this case, I would have already performed a full health history interview, including a PQRS-TIUA. All physical assessments need to be done directly on the skin, whether you are inspecting, palpating, percussing, or auscultating. It is never to be done over clothing. For the purposes of this video, some assessments will be done over clothes. Make sure to assess the anterior, posterior, and lateral parts of the chest. Envision the patient's lungs and begin with landmarking. This will help guide you through your physical assessment. First, I will landmark the lungs anteriorly. I will start at the suprasternal notch and I will work my way down the sternum to the angle of Louis. From here, I will go towards my patient's right side, which will bring me to the second rib. I will work my way down to the fourth rib at the sternal border. Then I will continue down to the fifth rib and find the fifth rib at the mid-axillary line. From the fourth rib at the sternal border to the fifth rib at the mid-axillary line, everything above these landmarks is the right upper lobe. I will continue to landmark the right middle lobe. I will start by finding the sixth rib at the sternal border and follow it to the mid-clavicular line. Once I've found this landmark, I know that from the fourth rib sternal border to the sixth rib mid-clavicular to the fifth rib mid-axillary is the right middle lobe. From the sixth rib mid-clavicular, extending laterally and downward to T10 in the back is the right lower lobe. Next, I will landmark the patient's left lobes. Again, I will start at the suprasternal notch and work my way down the sternum to the angle of Louis. From here, I will go towards the patient's left side, which will bring me to the second rib. I will work my way down to the fifth rib at the sternal border, and then find the fifth rib at the mid-axillary line. From the fifth rib at the sternal border, I will continue down to the sixth rib and find the sixth rib at the mid-clavicular line. From the fifth rib at the mid-axillary line to the sixth rib at the mid-clavicular line, everything above these landmarks is the left upper lobe. From the sixth rib mid-clavicular, laterally downward to T10 in the back is the left lower lobe. I will now continue with inspecting the chest. I can see that the skin color is uniform and consistent with the patient's genetic background. There is no cyanosis or pallor. I do not see any superficial veins or lesions. I do not see any bulging or retracting of the intercostal spaces, and there is no use of accessory muscles when breathing. I will note the position of the patient as they breathe. In this case, they are seated upright in a relaxed posture. I will take note of the mode of breathing, whether the patient is breathing through their nose or their mouth. In this case, my patient has a mask on, and therefore I would ask them. Next, I will tell my patient that I will be taking their pulse, but in fact will be taking their respiratory rate. The reason for this is because oftentimes if someone knows you are watching their breathing, they will alter it, which will cause a false result. I will assess the quality of respirations. I can see that my patient is breathing at a normal depth, not too shallow or too deep, and their breathing is silent, not audible. Their breathing is automatic, effortless, the pattern is regular and even. The chest expands symmetrically with each inspiration. I counted 7 breaths in 30 seconds. Therefore, my patient's respiratory rate is 14 breaths per minute, which is within normal range for an adult. Next, I will assess the symmetry of the chest wall by placing my hands on the patient's shoulders. I see that it is symmetrical. I will assess tracheal position, and I note that it is midline and not deviated. I will continue to examine the shape of the thorax. I see that the ratio of the transverse to anterior-posterior diameter of my patient is 2:1, which is considered normal. Next, I will assess the costal angle of my patient by placing my hands at the xiphoid process. I can see the angle is within 90 degrees, which is normal. From here, I will assess thoracic chest expansion. This can be done anteriorly or posteriorly. Again, by placing my hands at the xiphoid process and pinching the skin slightly, I will ask my patient to take a deep breath. I see that my thumbs move apart symmetrically and note smooth chest expansion. I will continue with general palpation. Using the fingers, gently palpate the entire chest wall. Validate with the patient any areas of tenderness upon palpation. Take note of any masses or crepitus you may feel. Make sure you do not forget to palpate laterally as well. Next, I will assess tactile fremitus by using either the ulnar edge of the hand or the palmar base of the fingers. Begin palpating over the apices of the lungs and move your way down. Compare the transmitted vibrations felt from one side to the other as the patient repeats the word 99. Normally, vibrations should decrease as you move down the patient's chest. Do not forget to assess laterally. Next, I will continue with percussion. Ensure appropriate technique by placing the non-dominant hand on the patient with the middle finger flat on the patient's intercostal space, and tap it with the dominant index finger and/or middle finger. Again, start at the apices of the lungs, percussing the intercostal spaces. Comparing one side with the other and move down the chest, making sure to follow the proper sequence for percussion. Percuss at 5 centimeter intervals and avoid the dampening effect over ribs or scapula posteriorly. Resonance predominates in healthy lung tissue. Note any dullness over the heart and liver. Make sure to percuss laterally as well. I will now auscultate my patient's lungs. I will instruct the patient to breathe through the mouth, a little deeper than usual, but to stop if they feel dizzy. Use the diaphragm of your stethoscope. Evaluate the presence and quality of normal breath sounds. Listen to at least one full respiration in each location. Again, proper sequence and side-to-side comparison is important. You should expect to hear 3 types of normal breath sounds in adults and older children. Bronchial breath sounds are heard over the trachea and larynx. Bronchovesicular breath sounds over major bronchi around the upper sternum. And vesicular sounds over peripheral lung fields. Evaluate normal breath sounds and note the presence of any adventitious sounds that are not normally heard over the lungs. Do not forget to auscultate laterally. This completes the anterior and lateral respiratory assessment. I will start by inspecting the posterior chest, again, looking at skin color, cyanosis or pallor, superficial veins or lesions. I will take note of the spinal process, which should appear in a straight line, and ensure the scapula are symmetrically placed in each hemithorax. I will now landmark my lungs posteriorly. I will ask my patient to tilt their head forward slightly to better visualize the spinal column. I will start by palpating the first most prominent protrusion in the back, which is C7. From there, I will count down to T1, T2, and T3. From T1 to T3 posteriorly, I will have my left, upper, and right lobes. From here, I will continue to count down to T4, T5, T6, T7, T8, T9, and T10. From T3 to T10 posteriorly, lie my left and right lower lobes. I will continue examining the chest and assess thoracic chest expansion at T10. Next, I will perform general palpation, assessing for any tenderness, crepitus, or masses. I will make sure to avoid both scapula. I will then assess tactile fremitus posteriorly, this time using the base of my fingers. Moving down the chest, comparing right and left side. I will continue with percussion, ensuring proper technique, listening for resonance, and again comparing right and left sides. I will finish my assessment with auscultation, listening for bronchovesicular and vesicular breath sounds posteriorly. This completes your posterior respiratory assessment. After completing your health history and physical respiratory assessment, you will now be able to identify your nursing care priority, provide relevant teaching and nursing interventions to help the patient with their situation. You should also be able to identify strengths and challenges that the patient has from the information gathered. Include follow-up instructions that demonstrate a collaborative approach with the patient. You always want to make sure you and your patient have an equal understanding of the next steps. Make sure to thank your patient and ask them if they have any questions. Ensure they are comfortable and have the call bell within reach if in a hospital setting. Make sure you wash your hands after having been in contact with your patient and their environment.